Okay, now we're
Okay,
recording.
it's going.
Okay,
Okay.
everybody, thank you for joining the call here. My name is Jesse Johnson. I work in the North Dakota Pharmacists Association office, and we are hosting this free CE webinar that will also be available for on-demand credit. And this is some work that has to do with our 2300 project that we have in place right now. And I will turn things over to Anna Skarphol, and she can take things over from here. So thank you all for joining.
Sounds good. Thanks, Jesse, for that introduction. So as Jesse said, my name is Anna Skarphol. I'm a P4 student. Currently on rotations. I'm actually in my last week of rotations, which is crazy. So I'm almost graduated here. And yeah, today we're going to do a hour-long continuing education, just kind of going over the current diabetes standards of care. And giving you guys a nice overview of what's included in those guidelines, because they can be a little bit long, obviously. And so sometimes it's nice to just get a refresher. And so just at baseline, I'm by no means an expert in all things diabetes, but I have spent an extensive amount of time kind of like reviewing the guidelines. And so that's what I'm going to go over with you guys today. And so I guess we will just get started. So like I said, we're reviewing the diabetes standards of care. Okay, I don't have any disclosures to make, and we're not going to be discussing off-label use of any medications today. A couple learning objectives to go over. First, we're going to discuss ways to navigate the guidelines for diabetes effectively. We're going to describe the timing and components of comprehensive diabetes medical follow-up, identify and recommend diabetes medications based on comorbidities, and explain the role of lifestyle interventions in managing prediabetes and diabetes, emphasizing collaborating with other healthcare professionals. So to get things started off, we're just going to talk a little bit about what are the standards of care in diabetes. So you guys might already be familiar. The purpose of the standards of care in diabetes is to provide clinicians, researchers, policymakers, and other interested individuals with the components of diabetes care, general treatment goals, and tools to evaluate the quality of care. This is a set of guidelines put out by the American Diabetes Association, and they're updated annually, which is really nice. A lot of our other guidelines don't get updated that often, and so things can kind of get out of date, but they really try to keep these up to date, partly due in fact to the diabetes is so prevalent, it's important to always be up to date on the treatment and everything. So diseases that are covered, type 1 and type 2 diabetes, along with gestational diabetes. And content included, they go really in depth through screening, diagnostics, and treatment of diabetes and associated complications. Things that aren't included in these guidelines are comprehensive treatment plans for diabetes-associated complications. And so the web link is there. I always get to the guidelines by just Googling diabetes standards of care, and that will take you straight to them as well. Next, we're going to get a little bit into how we're going to navigate the guidelines. So these guidelines, like I mentioned, are pretty extensive. They're actually divided into 17 different sections for ease of use, and each of the sections can be found in a separate PDF online. And the PDFs kind of break it into nice different topics, and we're actually going to go through each of those 17 topics through the course of this presentation. But just some basic tips for those PDFs. Throughout, you're going to find red boxes and gray boxes. The red boxes in the PDFs provide the recommendations from the ADA, and they just put them in nice red boxes to draw your attention to them. And then the text of the guidelines will explain further, the data behind each recommendation. And then there's also nice gray tables. And those provide just convenient summaries of important information. And so those are really nice if you kind of think like, oh, I remember reading this in the guidelines. I know that was summarized in a nice table. It's easy to go back and find them. They're in those nice gray boxes. And then in addition, if you're on the website, they have all 17 sections. And at the beginning, they actually have an annual summary of revisions document. This is really nice if you already stay up to date on the guidelines, because each year when that comes out, you can just review it. And those are the things that have changed within the guidelines. And so it's just a nice quick summary. So we're going to jump straight into talking about the sections within the guidelines. And so I'm going to have title headings and each one will have a number with it. So we're just going to start at the beginning and go 1 through 17. So the first section in the guidelines is titled Improving Care and Promoting Health in Populations. And so this just provides general information about how we should be taking care of patients with diabetes. Diabetes treatment decisions should be timely and based on the guidelines. That makes sense because they published a whole set of guidelines, so we should probably be following them in our treatment for diabetes. And within that, any decisions made about a patient's diabetes treatment, those should be made collaboratively with the patient, and based on a whole host of factors that we'll talk about throughout this presentation. And there's a really big emphasis in this set of guidelines on using collaborative care teams and multidisciplinary care teams as well as telehealth, which we know the importance of telehealth in North Dakota and rural communities. It can really help with continuity of care. And then, like I mentioned, it's really important to assess patients for food insecurity, housing insecurities or homelessness, financial barriers, social capital, social community support, and some of those social determinants of health. A special attention was given to that in this set of the guidelines, especially thinking about how expensive medications are. It's always important to take those factors into consideration when we're looking at a patient's care. And something that was interesting for me, I was asked to do this presentation during my 2300 1815 rotation, where we were really working to implement screening for social determinants of health. And so it's really cool to see that come up in the guidelines because it is so important and it really impacts our treatment if we're able to target it based on some of those social determinants. The next section, this is kind of where we get into more of the meat and potatoes of the guidelines. This one is titled Diagnosis and Classification of Diabetes. So as you can imagine, this section is mainly focused on the diabetes and classification, or the diagnosis and classification of diabetes. So just a quick overview here. Like I mentioned, we're not going to get into a lot of super specific things in this presentation. But type 1 diabetes, as we all know, is due to autoimmune beta cell destruction, as where type 2 diabetes is a progressive loss of insulin secretion, as well as insulin resistance. And they also talk a little bit about the classification of gestational diabetes, as well as some other subsets of diabetes. Here's some more examples of those really great gray tables that are pulled throughout the guidelines. They have them for a lot of things, but these two that I pulled out here, table 2.1 and 2.2, list out the criteria for diagnosis of diabetes as well as diagnosis of prediabetes. And so they lay out the A1C cutoff, which is 6.5 for diabetes, as well as for prediabetes, 5.7 to 6.4. Also looking at the fasting plasma glucose or the 2-hour test there as well. And then a reminder that pulls through in the bottom of one of these is you really need 2 different tests to diagnose a patient with diabetes. So just because you do a point of care, A1C test, that doesn't actually mean the patient has diabetes. It's just they need to do another test and they need more screening. And so looking at some more information that we have in this section, this next table that I pulled out is the criteria for screening for diabetes or prediabetes in asymptomatic adults. And so this is a great spot for pharmacy intervention. Kind of looking at maybe suggesting that a patient go in for screening. If they have a first-degree relative with diabetes or a high-risk race or ethnicity, maybe they have a history of cardiovascular disease or prediabetes, or they're diagnosed with gestational diabetes. Those people should all be screened for diabetes. And then for all other people, testing should begin at the age of 35 years. And so these are great recommendations that you can make to patients to get screened for diabetes. Other important information in this section, they talk more about the staging of type 1 diabetes, as well as more risk-based screening for type 2 diabetes in children and adolescents, and then screening and diagnosis for gestational diabetes. And another important update this year that I thought really had important tie-ins for pharmacy is they now recommend screening people for prediabetes or diabetes if they're on various medications that can increase your blood glucose. And so medications they bring up in the guidelines are glucocorticoids, statins, thiazide diuretics, HIV medications, and second generation antipsychotic medications. And so if you happen to have a patient who's maybe started on one of these or has been on it for some time, it might be a great recommendation to, ask if they've been screened for diabetes at their primary care visits. So the next section of the guidelines that we're going to move into here is section 3, the prevention or delay of diabetes and associated comorbidities. So obviously, if we can help a patient delay their diabetes, that is really our top priority. And so this section really nicely lays out a whole series of guidelines for things that we can do, both lifestyle recommendations and pharmacy-related recommendations to help prevent or delay diabetes. And so in patients with prediabetes, they should be screened at least annually. So get an A1C at least annually to monitor for progression to diabetes. And then another recommendation, and this is something I got to do on my 2300 rotation, was refer overweight or at-risk individuals to the National Diabetes Prevention Program. And so this is a program that encourages proper nutrition and increased physical activity for patients, which are things that are proven to help delay the progression of diabetes. And then another thing, this is a pharmacy-based recommendation. The guidelines recommend that metformin can actually be used as a preventative treatment for diabetes in patients who are at high risk. And so those would be people 25 to 59 years old with a high BMI there, elevated fasting plasma glucose, or an elevated A1C. So kind of in that prediabetes range. Another thing, as you guys know, prediabetes is associated with a high cardiovascular risk, so it's also important to screen for modifiable risk factors there as well. But something that was kind of interesting that I pulled out of the guidelines and I actually didn't know before putting together this presentation was that statin therapy actually has the potential to increase the risk for type 2 diabetes in people who are already at high risk of developing it. And that's just kind of because of the medication's mechanism of action. And so it's an important kind of like risk benefit assessment and conversation to have with a patient when starting them on that for cardiovascular prevention. There were a couple other updates made to the guidelines in this section that I highlighted here. They mostly had to do with kind of the management of type 1 diabetes. And there's a new, as you can see there in the second update, teplizumab infusion is a new medication for type 1 diabetics that can be used to delay the onset of symptomatic type 1 diabetes. So that's just something to be thinking about. If that's not a medication you already know a lot, maybe know a lot about, maybe look into it and kind of see what it is. It can be for anyone greater than 8 years or older with stage 2 type 1 diabetes. And so that's obviously a fairly specialized medication, but something that you might need to know about as a pharmacist. Moving on to the next section, section 4 is the comprehensive medical evaluation and assessment of comorbidities. So as you guys already know, diabetes is oftentimes more than just diabetes. There are so many things that tie into it, so many other chronic diseases that are related or linked to it, and so many different tests that need to be done. And it's a lot to coordinate for patients. It can really be a lot. And so Section 4 of the guidelines really lays out clearly what tests need to be done and when, and who should all be involved in the diabetes care process. This year, they really highlight the importance of person-centered communication. So I wanted to bring your guys' attention to this. I think I for sure have a habit of saying, like, someone is a diabetic or they are an obese person. But preferred language is actually saying a person with diabetes or a person with obesity. And that's just because that little change in language changes it from being their identity to being a chronic disease that they have. And so that's something that you guys can practice moving forward, is saying like this person has diabetes or this person has obesity instead of saying that they are a diabetic or an obese person. And then, as would make sense, people with diabetes benefit from a coordinated interprofessional team. And so they lay out, there's a whole host of people that should be on this team, including dietitians, nurses, nutritionists, exercise specialists, pharmacists, dentists, podiatrists, behavioral health professionals, and there's honestly so many more people that can be in that team as well. And that just helps a patient get the best care possible. So throughout the guidelines, they throw in various kind of like diagrams and pictures that kind of help to show what the words are saying. And this one I really liked, so I threw it into the presentation here. It just gives a good progression for how do we determine the goals of care for a patient and what do we take into consideration. And so I really like the first thing they start with in that orange arrow is assessing the patient. Diabetes care isn't going to be the same for every patient. And so it's really, really important to take into consideration the individual characteristics and priorities of each patient. And then as we go around the circle, we can see, the blue box is utilizing shared decision making. Some things that are important in that area are using patient-friendly language that patients understand. Agreeing on SMART goals with your patient, implementing a plan, and pharmacy can really be a part of this plan, depending on, what area of pharmacy you can work in, helping a patient understand their medications, maybe at a community pharmacy level, but also ambulatory care pharmacists are managing those medications and starting new ones to help patients get the tightest control on their diabetes. So I thought that was a great diagram there. And then moving on in this section, another really important pharmacy intervention that we can make for patients is kind of coordinating some of that preventative care. And so immunizations are obviously really important for patients with diabetes. They help to reduce hospitalizations and reduce the risk of getting infections like COVID-19 or the flu, which we know can be really severe. And when you have comorbid conditions, they can end up being worse. And so for the most part, they say just go along with age-appropriate recommendations for our children and adults with diabetes. Same with the COVID and flu, they should just stay up to date with the annual formulation. And then for the pneumonia vaccine, for patients who are 19 to 64 with diabetes, they can get a dose of PCV20. And then those who are 65 plus can also get a dose of PCV20 as well. And then the guidelines here just recommend that RSV, zoster, Tdap, and Hep B should be given out per CDC recommendations and the ages associated with those certain vaccinations. This one's kind of hard to see, but there was really important information in this table here within the section 4 of the guidelines. And so I wanted to include it just so you had an idea of kind of what some of the things in the guidelines look like. And so this table really lays out clearly when patients need to be receiving each aspect of their care. And so I've put orange box or red boxes around a couple things to really highlight where pharmacy might be able to intervene. So we can see here in this first box, medications and vaccinations. So patients should be assessed for their vaccinations at their initial visit and then annually. And some things are also assessed at every visit. And so if you look there, their current medication plan, medication intolerance or side effects, those can be assessed at every visit. And those are great questions you can ask in a community pharmacy setting as well. Just asking them how their medications are going, maybe how their Ozempic titration is going, or things like that. We can assess all the time. Under social life assessment, I highlighted here these social determinants of health. Those are best if assessed when a patient is initially diagnosed and then also assessed at every follow-up visit. And so that's something that pharmacy can definitely play a role in. Some other things here, blood pressures are really important for these patients, as well as foot exams. We learn how to do those in pharmacy school. And so they're definitely something that kind of part of the coordination of care that we can be involved with. Then also A1C, making sure if we're able to access information that a patient has updated A1Cs in the last 3 months, and if not, referring them to get one done. Just to make sure they're always up to date and we're having a, tight control on their diabetes and understanding where they're at. This section really is quite a long one, and they also include really in-depth management of some comorbid conditions. Listed, there are a whole variety of things: disabilities, hepatitis C, hyper and hypoglycemia, periodontal disease, sensory impairments, and kind of a specific focus on statins as well. So there's a whole host of information in this section of the guidelines. If you have a patient who has a specific comorbid condition, you can definitely go check in the guidelines. They probably have something about it here in section 4. There was new information this year on fracture risk, bone fracture risk in individuals with diabetes. I didn't include specifics, but there really was quite a bit of information there. And then another thing that was really important is selecting medications for patients with low risk of hypoglycemia to reduce risk of falls when it comes to bone health. And the hypoglycemia is something they really targeted in this year's edition of the guidelines, reducing, intensive insulin dosing or other medications like sulfonylureas that cause those hypoglycemic risks, because in individuals who aren't aware of them, they can cause really severe problems, like falling, passing out, and that can cause a lot of issues. And then also making sure patients are meeting their calcium and vitamin D goals. That can be a pharmacy intervention, just helping a patient get a supplement. The next section, section number 5, is facilitating positive health behaviors and well-being to improve health outcomes. And here it's more interventions. Turns out there's interventions throughout where pharmacy can really step up. So individuals with diabetes should be strongly encouraged to participate in diabetes self-management education support groups. So pharmacists can actually become licensed diabetes care and education specialists and help to provide some of these services and classes for individuals. I don't know a lot about it, but it can actually be reimbursed by Medicare, these various services. Within this section, they also talk about a lot of those lifestyle interventions for diabetes. So medical nutrition therapy and weight management, targeting a 5 to 7% loss, as well as meal planning. They lay out really specifically what kinds of food should be included in meals. And there's also new recommendations related to religious fasting, which I thought was really important, as that is something that quite a few of our patients might participate in. They also talk about physical activity guidelines, smoking cessation, including cannabis with that which hadn't been incorporated previously, supporting positive health behaviors, and psychosocial care, which has shown to be really, really important. As you can imagine, diabetes is a really difficult chronic disease to have. It's constant management every day. And so that's something that they bring up. The next section is glycemic goals and hypoglycemia. This section talks a lot about when we need to monitor patients' A1C depending on their control. And so as you can see here, in patients who are well controlled, and so that would be traditionally an A1C less than 7, but we'll see later for some patients it's not always 7. Those patients should be monitored. Their glycemic status should be assessed twice a year. And then in patients who are not at goal, we like to assess them quarterly to help them meet their goals. They also draw our attention to the use of single-page glucose reports for CGM, and using standardized report layouts. That can really help patients if they're able to see the CGM data and that standardized report. It just puts a visual to what their blood glucose is doing and can really help patients to get a tighter control on their glucose. And then here we can see, like I mentioned in table 6.3 was that A1C less than 7 goal. They also have the classification of hypoglycemia and what level 1, 2, and 3 are there, as well as in table 6.1. I really like this one. It has the, it takes the A1C and compares it to what that would look like as a blood glucose reading. That's a really great visual for patients, just because they don't always know what the A1C numbers mean, but they get pretty used to seeing what those different and various blood glucose readings mean. So that's an important one to kind of show your patients sometimes. Moving on, there was a couple updates in this section, mostly talking about de-intensifying those hypoglycemia causing medications like I brought up before, things like insulin and sulfonylureas. Especially if patients are at high risk. And so table 6.5 in the guidelines brings up what is a high-risk individual with hypoglycemia. There's all sorts of things that play into that, but things like intensive insulin therapy, end-stage kidney disease, cognitive impairment, and then also some of those social determinants of health, like food insecurity, low income status, homelessness, or fasting for religious reasons. Those can all play into hypoglycemia risk. And so that's something important for us to assess. And then one recommendation that they make, glucagon should be prescribed to all individuals taking insulin at high risk for hypoglycemia. That's often something that gets left up or left off, or patients don't always pick up, but it is really important to have on hand. And they also, this is new this year, they put all the hypoglycemia recommendations in section 6 before they'd kind of been scattered throughout the guidelines. So next here, this slide is really nice. This kind of shows those shifting A1C goals. So depending on person or disease features, that A1C goal can change. And so we might have a more stringent A1C goal in someone who's newly diagnosed, they're in their 50s, they have a lot of life in front of them, they don't have a lot of comorbidities. But maybe for someone who's older, has a lot of chronic diseases or something like that, our goal might look more like 8. We're not trying to keep as tight of a rein on it. And maybe they're at a high risk for hypoglycemia, and so we can't keep as tight of a rein on it. There's all sorts of factors that can play into that, but this is something that you can, reference if you're wondering why a patient's goal is what it is. Moving on to diabetes technology. Obviously, as time goes on, diabetes technology is advancing, and we're really able to help patients manage and keep a tight watch on their glucose using continuous glucose monitoring now. And they also talk about when blood glucose monitors should be used. And so if patients are on insulin therapy, it's obviously appropriate to have a blood glucose monitor. If they're not on insulin therapy, there isn't any clinically significant reductions in A1C, but it can still be really helpful for patients to see, like, oh, that's what my blood glucose is, after I eat this or whatever. And then CGM, there's 2 different kinds. We've got a real-time CGM, and then also an intermittently scanned CGM. So that's just important to be aware of. But something they added this year, there's a new focus on all healthcare providers, including pharmacists, being familiar with CGM. As pharmacists in a community pharmacy, we're often dispensing the CGM, but as you guys know, sometimes patients come in and they maybe don't understand how it works, or they don't understand, their meter's not working, or they don't understand their report. And so those are all things that if we're well versed in them, we can really help coordinate the whole diabetes care process. Another thing that I just found was interesting, and so I threw it in here. There are some different substances that actually interfere with how the continuous glucose and the glucose meters are able to read. And so really common things like acetaminophen can actually cause the blood glucose readings to be inaccurate. And if you look in the guidelines, there's actually a specific table that looks at different brands of CGM and how different substances impact them. And so if you suspect or notice that a patient is on, maybe they take a lot of Tylenol or something and they're not getting accurate readings, this might be something to look into for your patient. And so you can check out section 7 and look to see if their specific brand of CGM ends up having a medication interaction with it. The next section is section 8, and that's obesity and weight management. for the prevention and treatment of type 2 diabetes. So obviously this section gets really into the specifics of how we're going to manage obesity and weight. And they also talk a lot about the different medications that are FDA approved for obesity. This is really a hot topic recently with things like Ozempic and Zenpep and those GLP-1 medications that are used for weight loss. They also talk about using measurements more than just BMI, including waist circumference, waist to height ratio, and things like that, as they provide a better picture of what obesity might look like. And then this last recommendation here, GLP-1 and GIP or GLP-1 combination drugs are preferred options for weight loss in diabetes. And so that is their official statement. Those medications are preferred. Throughout this section, there's actually a really nice table that lays out every single FDA-approved medication. I didn't include the whole thing because we didn't have time to go through it. But for each medication, they provide all of this different information. So they talk about the average wholesale price, kind of what the expected weight loss is with the different dosages, the common side effects, and the possible safety concerns. So this is a really great resource for pharmacy if your patients are maybe on a medication and experiencing side effects, or what have you. You can go and look at this table and see like, yeah, that is a common side effect, but this other medication maybe doesn't have that side effect. Or just looking at maybe cost is an issue, and so you need to find a cheaper medication for someone to make a recommendation. Whatever, this really is a nice table with lots of information that's very relevant for us. The next section, moving on, is pharmacologic approaches to glycemic treatment. So this is really where we get into the pharmacy part of the guidelines. We're now looking specifically at their recommendations for pharmacologic treatment. So it goes through all of the different medications and medication classes that are available, their associated costs, and specific recommendations for both type 1 and type 2. Obviously, it's important to distinguish between those two. We'll get into this on the next slide, but they provide really great graphics that help you prioritize when to start different things based on comorbidities. But a couple major takeaways that I pulled out of the guidelines. They're really trying to get away from just starting patients on insulin right away because we have so many other great options available to us. And so they actually recommend that for type 2 diabetes, GLP-1s should be recommended as an injectable medication over insulin. And mostly that has to do with there's just less of a risk of hypoglycemia. And then also the importance of assessing for comorbidities like kidney disease, heart failure, and obesity, because we can target the diabetes treatment to kind of fit those things. And so here is the nice kind of chart that I was talking about. There's so much information in this, and I'm sure it's kind of showing up small on your screen, so it might be difficult to see, but the title of this table is the use of glucose-lowering medications in the management of type 2 diabetes. And it takes into consideration all sorts of chronic diseases and how that's going to play into our diabetes treatment. In a really nice, like, visual way that I find is easy to follow. And so if you look on the left side of the screen, we have different kind of cardiovascular conditions. And so if our goal is risk reduction of cardiovascular conditions, we can kind of follow those down. And a lot of the recommendations on that side are going to be putting a patient on a GLP-1 or an SGLT2. As we know, those can reduce cardiovascular risk. If your patient has heart failure, an SGLT2I is a great option. Or CKD, we kind of talk about some various options there. Again, the SGLT2Is are a great option, making sure those patients are on ACEs and ARBs as well. So tying that blood pressure management in. And then on the other side, you can see here, we talk a little bit more about weight loss on the right side of the screen. And so they talk about the different medications that show very high weight loss. Those are things like our GLP-1s, excuse me, like semaglutide, and things like that. And then ones that are maybe more weight neutral, like metformin or the DPP4s. So not quite as good for weight loss if that's what we're really, really looking at. And then also medications that are really effective at lowering glucose to ones that are less effective. And so an interesting one to talk about, insulin. Insulin is really, really good at lowering glucose, as we can see from this table, but it can cause some weight loss. It's not going to, or it can cause weight gain, not weight loss, excuse me. And so kind of weighing what we're looking for a treatment for our patient using these flow charts can really, really help to tailor it towards their specific needs and goals. Again, there's more tables and charts. There's a lot of tables and charts. But this was another great table. If you're less of a flow chart person and more of a table person, this one lays out each of the medications and those different benefits that go along with them. So again, it's kind of the same information that was in the last chart, just presented in a different way. And so we're looking at how effective is it at glucose lowering? What's the risk for hypoglycemia with it? What kind of weight change do we see? Does it have cardiovascular benefits? Does it have renal benefits? What's the cost of the medication and what are other clinical considerations? I think things like this are so great, especially for me as a student, because it just provides an entire summary of all of the diabetes medications in one screen. And so if I can't remember like, oh, which SGLT2I has cardiovascular benefit, it's really easy to go here and I can find, as I kind of highlighted and read some different things that were of interest, I can find like, oh, perfect. Canagliflozin or empagliflozin are the two that have benefit. And again, this is a real benefit to the guidelines being updated every year, is that that this information is really pretty up to date. So unless medications have come out in the last calendar year, they should be on here. They should be up to date. This is information you can really rely upon and trust. There's also a couple recommendations when it comes to type 1 diabetes here. They talk about the preference for insulin analogs or inhaled insulin over injectable human insulin. And that's just, again, for hypoglycemia risk. And then also using CGM early in patients with type 1 diabetes. And then there were some updates for type 2 diabetes as well. A lot of these are things we've already talked about, but just the importance of updating treatment plans regularly, not just putting a patient on an insulin regimen and then never adjusting it. Using early combination therapy to help patients meet glycemic goals right away, and also really help them manage their weight. And so, like we mentioned before, that's using those GLP-1s or other medications to help a patient lower their weight to get a tighter control on their diabetes. They talk about those specific guidelines for SGLT2Is in heart failure to prevent hospitalizations, reassessing insulin dosing and really moving away from using too much insulin, especially if you start a patient on a GLP-1, as that can obviously lower their blood glucose. Yeah, so those are some important recommendations that they make that were new this year. So after they have section 9, which was the general chapter about pharmacologic management of diabetes, sections 10 and 11 kind of break down pharmacologic management in terms of cardiovascular disease and heart failure. And so a lot of these sections, they do tie in more pharmacy components just specifically for cardiovascular disease here in section 10. And so, there's a lot of risk factors for ASCVD, obesity, hypertension, dyslipidemia, smoking, CKD. Those are all things that we can manage with medications, which is really great. And they should all be assessed annually to prevent and manage both ASCVD and heart failure. And then here our blood pressure goal for our patients who have diabetes and cardiovascular disease is going to be, less than 130/80. I'm not going to get into this chart too much here, but they provide recommendations for hypertension treatment in our patients with diabetes. Mostly the recommendations are to just use an ACE or an ARB, but if you really are getting into it, or maybe they can't use those, they provide other great recommendations there for which targeted therapies, or if you need to do dual or triple therapy, what therapies we should look at. Another important aspect of cardiovascular disease risk management is the use of statins. And so we talk about our high intensity statins and our moderate intensity statins, and they have a nice table with those in the guidelines. Patients should get a lipid panel every 5 years after age 40. And anyone with diabetes, actually, who's age 40 to 75, qualifies for a moderate intensity statin. So if you remember learning from school, there's all sorts of reasons you can be on a statin and all sorts of qualifications. But this is just a blanket statement. Anyone who has diabetes and is at least 40 and can tolerate a statin should at least be on moderate intensity statin. They might qualify for a high intensity statin based on other characteristics. And then if they can't tolerate a statin, there are a couple other therapies there, those newer agents that we can use to help lower their lipids as well. Aspirin or clopidogrel can be used as a secondary ASCVD prevention as well. But if using it for primary prevention, risk should be weighed. And looking a little bit more, SGLT2Is and GLP-1s are great therapies to reduce cardiovascular disease risk. And so they kind of talk about that here in this flow chart. But patients who have diabetes and any one of the following, ASCVD, heart failure, or are at high risk for ASCVD, more than likely will qualify for an SGLT2 or a GLP-1, and specifically the ones with proven cardiovascular benefit. And so that's going to be kind of a conversation to have between the patient and the provider, what kind of fits their goals, fits into their cost constraints, the best. And so we can look at both of those medications for these patients. So next, like I mentioned, section 11 is kind of the same concept, but we're looking at kidney disease instead of cardiovascular disease. And so this is going to lay out some recommendations for when we should be screening for their eGFR for patients with type 2 and type 1 diabetes who've had the disease for at least 5 years. Glucose management should obviously be optimized in patients with CKD to slow kidney decline, because we know that these two disease states kind of go hand in hand. Worsening diabetes can impact kidney function, and kidney function can make diabetes worse as well. And then here, we recommend an ACE or an ARB for patients with both diabetes and hypertension, based on their albuminuria. So you can look at their labs and kind of determine if the patient would qualify for being on ACE or ARB therapy to slow progression of their kidney disease. And here's another great table that I found. I really like the visual tables, and so I kind of threw them in here just so you knew what was sort of available within the guidelines. But when we're looking at kidney disease, there's all sorts of things, just like in the other sections, that we can do: healthy diet, physical activity, smoking cessation, and weight management, assessing their risk every 3 to 6 months. And then here it breaks down what our first line drug therapies are going to be. And so we've already kind of talked about these, but it's the SGLT2Is for kidney disease, as well as metformin, and then using a RAS inhibitor, like we just mentioned, as well as that statin therapy. And then it talks about additional risk-based therapy as well that you can use for these patients. Moving on, these last couple sections in the guidelines get pretty specific, and they aren't always quite as pharmacy related, but I thought it was important to include them just so you guys knew they were there. And so section 12 takes a look at kind of the retinopathy, neuropathy, and foot care in these patients. When those should be assessed, it's generally, they should be yearly. Patients should be having eye exams, foot exams, nerve exams. So that's the important thing to note there. And they include treatment recommendations as well for those different conditions. Section 13 looks at older adults and how their diabetes care is different. Some big things here: screening patients for polypharmacy. If they're on 7 different medications to manage their diabetes, maybe we can cut back on a few. Maybe we can de-intensify some therapy. And then older adults should also be screened for neurocognitive decline, as that's something that can really impact their ability to self-administer medications. And then we talked about this before, but higher A1C goals in the older population. Section 14 talks a lot about diabetes treatment in children and adolescents, and the importance of assessing their treatment, making sure it's appropriate, screening for psychosocial and behavioral health concerns, as well as diabetes distress. Something that I thought was interesting, and so I tied in here, was that those GLP-1s or SGLT2s can be used in juvenile type 2 diabetes if they don't meet their A1C goals on metformin. And so metformin is going to be first line for them, but those agents can be added on, just kind of like in adults. There's a whole section on management of diabetes in pregnancy, which again, I'm not going to get into, but if you needed to find out more information on that, heading to this section of the guidelines would be a great start. And then section 16 of the guidelines talks all about diabetes care in the hospital. Something that I pulled out from this section was that if a patient hasn't had an A1C done in the last 3 months, that's a great time to do it, is when they're in the hospital. You got them there already, so just get an A1C done. Some providers are really good at doing that, and others aren't quite as good. And then just remembering that our target glucose range in the hospital is not the same as it is outpatient. We're looking at trying to keep them between 140 and 180 would be ideal. They can also keep their home CGM on if possible, and then it gives recommendations for how to monitor. Usually it's just going to be insulin in patients or inpatient because it's easier, and then monitoring with the blood glucose monitors. They also bring up the importance of a structured discharge plan, which this year on rotations, I've really seen the importance of this. Sometimes patients come in and their diabetes regimen is definitely a mess. They don't know when they take any of their medications. They don't know what's going on. And so the importance of trying to coordinate care as they transition out of the hospital to make sure they understand their medications, they understand what they need to do on discharge to keep their diabetes under control. And the last section, we'll just really briefly hit on this. It's titled Diabetes Advocacy, and it's just a bunch of position statements. So the American Diabetes Association spends quite a bit of time and money advocating for people with diabetes. And so there's all sorts of various statements. If you're interested in diabetes advocacy, this would be a great section to look at. So we've made it through all 17 sections. That was kind of a speed run of the guidelines for sure. But we're going to move on to a couple assessment questions here now. So our first question, this is going to have to do with immunizations. So RJ is a 63-year-old male with type 2 diabetes. He comes to your pharmacy after his biannual diabetes follow-up visit to receive any necessary vaccines. They already received this year's flu and COVID vaccine and got the Shingrix series and tetanus vaccines 3 years ago when they turned 60. What vaccines would you recommend today? And I'll just give you guys a second to think about it. You can throw an answer in the chat if you want to, but we won't spend too much time on these. Someone messaged me and they said A, or number 1, which is correct. Like we mentioned earlier, the pneumonia vaccine would be indicated for this patient. And they haven't received any of them in the past. And so that PCV20 would be appropriate. And then they are also of age to get the RSV vaccine as well. They do not need the meningococcal vaccine as they don't qualify for that based on CDC recommendations. Our next question, this one should be pretty easy. Janet is a diabetic is an example of person-centered language. True or false? We'll move on here. I hope I gave you guys enough time to think about it. Exactly. The answer is false. So Janet is a diabetic is language that we should be moving away from. We'd like to say, Janet has diabetes instead. Just to remind Janet that diabetes is a chronic condition. Diabetes is not her entire identity. Okay, moving on to our next question. Oh, this one's kind of long. So KP is an 86-year-old female with type 2 diabetes who presents to your pharmacy and reports they have been experiencing episodes of dizziness, shakiness, sweating lately at home. When she tests her blood glucose after these episodes, it's only 45. What is an appropriate recommendation you could make based on their home medication profile, which I've included on the screen here? And then you also found their A1C is 8.5%. So I tried to make this one easy. The options that we have would be to A, increase long-acting insulin from 20 units to 22 units, increase semaglutide dose from 1 to 2 milligrams, and continue sitagliptin. C, recommend that KP does not need glucagon rescue therapy available, and D, discontinue glipizide due to hypoglycemia risk. Right, I got a couple people sending me answers. D would be the correct example, discontinue glipizide due to hypoglycemic risk. Just a little fun fact, I threw B as an answer in there. This patient is on both semaglutide and sitagliptin, which doesn't make a lot of sense. It's a duplication of therapy, but I actually ran into a patient on my rotations who was on both of those medications at the same time. So it's important to always be assessing a patient's medication profile and making sure that everything makes sense. If we were really going to tailor this patient's therapies, we'd probably cut down their insulin or, maybe stop glipizide altogether. Might not be the best medication for an 86-year-old female. So there's a lot of things you could do to help tailor their therapy. And our last question here. At your community pharmacy, you complete a prediabetes screening on LJ and they screen positive for prediabetes. What can you recommend? First option would be to offer to refer LJ to the National Diabetes Prevention Program. Tell LJ they need to start insulin to prevent their diabetes. Refer to LJ as, that's supposed to say as a diabetic because he has screened positive. Or tell LJ that they are healthy and do not need to follow up with their primary care provider. And exactly, I got an answer A. That is the appropriate course of action here. We want to refer LJ to the National Diabetes Prevention Program. That's our best course of action when we find out a patient has prediabetes. Although they screen positive for prediabetes, that does not mean they have diabetes. And so we don't want to tell them that they have diabetes. And they should follow up with their primary care provider. It would be also an appropriate thing there. And so there's our sources, just the guidelines. And here is the last slide, what you guys have been eagerly waiting for. This is how you can get your credit for this course on CEI Impact. But I'd also like to open it up if anyone has any questions. You can ask those now as well.
Yes, great job, Anna. And I'll just add to everyone on the call, if you need this code sent to you at a later time, feel free to reach out to myself or Anna. And if you have any colleagues or anybody that you know of who would like to watch the recording of this presentation, feel free to reach out. We'll also be sending an email out about that, but just wanted to put that plug in there.